Okay, welcome everyone to our fifth lecture in our Mrso, Mrmd, Mrse certification course. I'm Jason Parker. I'm going to talk specifically about the ACR MR safety manual today. This will be similar, at least in structure, to the first talk I gave, which was an introduction, which was primarily based on the safety manual, although we'll go into greater detail this time around. We're going to talk specifically about a few issues that we've had in our institution, how policies get approved and augmented, as well as give you some real-world examples of some of the more kind of emerging threats that have been occurring in the MR environment, primarily thermal heating. With that said, a few things I'd just like to recall from the first talk we had, just so we're kind of on the same page. There aren't any grandfather provisions in the new ACR MR safety manual. If you had something that are approved as being acceptable previously, whether it was from the Joint Commission or the ACR, that is not the case anymore. We have to meet all the requirements in the new 2020 ACR MR safety manual, which we're going to be reviewing today. As we talked about, MR safety is not explicitly a part of accreditation, but it can be a part of an inspection. So if you have a site visit from the ACR, which they have promised to do at every site at least once every 3 years now, MR safety can and most likely will be a part of the inspection. With that said, you have to specify an Mrmd on your ACR application, and they have to attest that they are the primary party responsible for MR safety in your healthcare facility. So although it's not directly, directly part of the application, it is indirectly part, in that the Mrmd must attest that they are overseeing the implementation of safe MR practices. There's a few big changes outlined in the ACR MR safety manual that require significant investment to implement. Staffing is probably the one that's caused the most challenges so far, and something we've all paid a lot of attention to recently in trying to address the staffing requirements of the new document in a way that is financially feasible for us, at least in the short term, understanding that we're working towards a long-term solution that will probably be more in line with what the document envisions. And of course, we're appointing Mrmds, Mrsos, and Mrses. I do want to mention once more that the ACR is not alone here. They're not the only body that's increasing the amount of attention they're focusing on MR safety. Most of these issues are of concern to the Joint Commission. When the Joint Commission came to visit the AHC, I think it was last year, those of you who are in the meetings with the inspector related to MR and physics, you probably remember that I got, I would say, beat up by the inspector, who was very interested in MR safety and had lots of very specific questions about what to do with prisoners and other difficult situations. So it is of great concern, and you should expect, although you might get an inspector who isn't that keen on MR safety, more and more it's becoming a big topic with them. The Veterans Affairs Department is also getting more and more honed in on MR safety, and we're going to see a few of their publications today that have been used by the ACR in constructing their MR manual. Lastly, I'll just mention we're a really large system. I think everyone knows that, and that does make it very hard for us to develop broad safety policies that can work for everyone. And I know you all experience that whenever I or someone else comes up with some new MR policy that we want to push out. We're immediately met with all the different scenarios at all our different sites, and we try to scope those scope those policies in such a way that they'll work for everyone. But in doing so, at times we make them less effective, and so that is a major challenge for us. I think the best way to address that is for as many of you to participate in the MR Safety Committee as possible and help us develop language and policies that are going to work across all of our sites. As we talked about in our last meeting, we have had accidents at IUH, including in the last year. Almost all of these cases, if you review them though, could have been avoided through better education of our MR technologists, as well as better adherence to MR safety policies for physicists, MDs, and technologists. Okay, with that said, outline, we're going to talk about policies and procedures and incident reporting briefly, MR personnel and staffing, briefly screening and gowning, talk about special patient and worker populations, including pregnancy, prisoners, and parolees. We'll talk about implants, devices, and objects and how they're classified, emergency responses, briefly touch on complex MR settings like intraoperative MR and PET MR, and then we'll revisit those physical dangers and phenomena that we talked about in my first discussion, the four kind of big physical forces that we are concerned about in MR. These are detailed in lots of depth in the ACR MR safety manual. We're just going to spend about 10 minutes talking about them. The only other thing I wanted to bring is that I've talked to at least 3 Mrmds now, a lot of Mrsos and myself, and heard lots of different concerns so far about the direction we're heading in. And in almost all cases, I agree. At least 2 of the radiologists I talked to did not really, were not convinced that someone who was in a reading room most of the day could somehow be completely responsible and liable for everything that goes on in Zone 4. I don't disagree with that. I think it is a challenge for the radiologists to somehow do their day job and ensure that everything is happening correctly in Zone 3 and Zone 4. This is just one example of the type of questions I get from our MRSOs or our technologists almost on a daily basis. They understand something is approved by the FDA or it's considered MR conditional, but they're just not comfortable doing it, such as a patient under GA. In many cases, I'm not comfortable doing it at all. Everyone probably knows that I've been pushing for us to not allow weapons, especially firearms, into Zone 3. I think that there should be safes outside Zone 3 where they get locked up, but that's not currently the ACR's position. Anyone who's a fan of The Office, I'm a huge fan of The Office, so this is a line I try to apply to everything. I don't know how well it fits here, but I guess from my perspective is the ACR has essentially told us this year, those might all be valid concerns and legitimate concerns, but we have a structure that we're moving forward with that we all need to abide by. Certainly we can implement policies that are more conservative than what the ACR has laid out, but it is not a good idea for us to deviate from those policies unless there's a really good and documented reason for it. Okay, policies and procedures. The manual states specifically that each MR facility will name a physician Mrmd. Their responsibilities include ensuring MR safe practice guidelines are established and maintained. This is what we talked about in my first talk. However, it's the MR facility's administrative staff, including the Mrso, who must ensure the policies and procedures that result from these guidelines are implemented and adhered to. Incident reporting is something I think that we can improve in our system. The ACR specifically states that procedures should be in place to ensure that all MR-related adverse events, safety incidents, or near incidents that occur are reported to the Mrmd within 24 hours or 1 business day, and then are used in continuous quality improvement efforts. I think that we can improve our reporting of near incidents, and I think that we can improve our use of near incidents and continuous quality improvement efforts. And so I am going to encourage everyone to go out of your way to report near incidents. It doesn't make you or any of us look bad. What it really does is it gives us data to use to understand where the weak points are in our safety chain and try to improve things. You all are probably already familiar with MedWatch. This is a website or a system that's stood up by the FDA. And they request that all adverse events, i.e. where a patient is harmed, are reported to them via MedWatch. In the AHC, we usually do that through Shelley Curtin. This is a nice article where some authors at Stony Brook Hospital go through a handful of incidents that they had at their hospital and kind of give statistics on what were the most common incidents and some of the procedures that they put in place to rectify them. I'm going to post this article on the website with the video so you can read it, but I'm just going to give you some kind of key takeaways from it. First of all, the WHO defines a near miss as an error that has the potential to cause an adverse event, i.e. patient harm, but fails to do so because of either chance or because it is intercepted. That second one, intercepted, I think we do a lot of. And so I would encourage you, when you intercept an error that could have harmed a patient, you should report that as a near incident. Again, it's not because you did something wrong, you did something right, but it gives us a chance to acquire more data and better understand how we can improve our MR safety system policies and procedures. They found that data from the patient incident reporting system over a 12-month period had a total of 22 near misses that were specifically related to MR screening. So they had 56 near misses, 22 of them were specifically related to MR screening. Analysis of those 22 showed that half of them were patients who had non-compatible MR pacemakers. Kind of scary. I know this happens in our system quite a bit, where we find out someone has a pacemaker when they show up. That's not how it's supposed to work, obviously. When you do catch those are near incidents, and I hope that you will report them for us. Let's see, only 10 out of those 22 patients had actually completed the technologist MR safety questionnaire form. So this is obviously a major issue and something that we need to ensure. In all cases, we need to have the MR safety questionnaire form completed. We'll talk about that a little more when we get to the screening part of the discussion. Staffing and MR personnel, again, a lot of this is review from the first discussion. MR personnel are defined as all individuals responsible for safety in zones 3 or 4. And when we say responsible for safety, that means they could be responsible for themselves or they could be responsible for others. If you're responsible for safety in zones 3 or 4, you're considered MR personnel. MR personnel must complete annual safety training, and the documentation must be kept by the Mrso. As all of you know, I think we have we complete level 1 and level 2 training via the MR Safety Committee website, and there are spreadsheets behind the website that track scores and when everyone took the test, and all MRSOs should already have access to that. If you don't, send me an email and I'll make sure you get access to it. It's very easy. As soon as someone tells you they passed, you can go in and verify that they did. You should always verify that they do, and recognize that during an inspection from the ACR or the Joint Commission, it is very possible they will ask you to prove that you have verification of who are MR personnel and that they have had their testing in the last year. It's very easy. You just follow the link and pull it up and show them, but it's not easy if you don't know where it is and have it bookmarked and all that. So do reach out to me if you don't. Non-MR personnel, in an odd kind of definition, are considered any individual who has not within the previous 12 months successfully undergone designated formal MR safety education. So they're not defined as kind of the opposite of MR personnel, which would be people who aren't responsible for safety. Instead, they're defined strictly based on whether or not they've taken testing in the last 12 months. If you haven't taken your testing in the last 12 months, you're not MR personnel. So, you might feel like you are because you feel like you're responsible for safety, but you're not qualified to be MR personnel, and you shouldn't be considered MR personnel. And so just recognize that it is all of our duties to make sure that we're taking our annual testing and checking in with the MRSO and making sure that they're aware that we've taken it, and if they want to grant us access, that they are able to verify that we've taken the training. As we've discussed, there's 2 levels of training. Level 2 is the more robust training. Level 2 MR personnel are individuals who have been more extensively trained and educated in broader aspects of MR safety issues. This is defined specifically in the new MR safety manual, including, but not limited to, but you must have training in RF safety, DVDT related safety of the time varying imaging gradients, cryogen safety, contrast agent safety, and others. The old definition that was around before the 2020 manual was level 2 MR personnel are people who are responsible for themselves and the safety of others. I like this definition a lot more than the new one. I feel like it was simpler and more specific. So in the old definition, if you were responsible both for yourself, but also for the safety of others, so when anesthesiologists are coming in or nurses are coming into zone 4, you're a responsible party, you were level 2 MR personnel. They've changed it a little bit now to focus more on the education aspects of it. I think in your head, it's probably still valid or useful to remember that level 2 personnel are in fact responsible for the safety of others. Level 1 MR personnel are individuals who have successfully passed the safety educational efforts sufficient to ensure their own safety and to ensure that they don't pose a threat to themselves or others that work in zone 3. And that also, of course, includes in zone 4. The old definition is simpler. They're responsible for their own safety. So again, I think that these two older definitions still apply, but the focus is a little bit more on education now. Access restrictions are something we've dealt with a lot in our system and cause a lot of confusion and need to be reviewed annually. I know we had one site in our system, I think last year, that had upwards of 800 people who had access to zone 3. Many of them didn't work here anymore. We've had plenty of other sites that had well over 100. And this is due to people getting access over the last 5 to 10 years, probably taking their training, hopefully before they got access, but then not taking it again. And thus not meeting the definition of MR personnel anymore. And we've done a large purge across most of the system to get those numbers down to reasonable levels. When it comes to access though, MR personnel can have independent access to zone 3 and zone 4 if necessary. And we do have lots of cases where someone is considered MR personnel, they've taken their level 1 or their level 2 training, but they don't have independent access to zone 3 or zone 4 because it's not necessary. And that's determined by the Mrso, and they do it on behalf of the Mrmd, and there can be consultation with the Mrmd if necessary. I encourage our Mrsos to let as few people have independent access to zone 3 and zone 4 as possible. Obviously, that's to minimize accidents. There are plenty of folks who I think need to be able to quickly and independently go into zone 3. If you're a radiologist who's working a lot in zone 3 and zone 4, if you're an anesthesiologist who's working a lot and needing to see patients quickly in zone 3 or zone 4, or potentially respond to an accident or a code, it makes sense for you to have independent access. If you're only going down once every few weeks or once every few months, the most that you'll have to do if you don't have independent access is knock on the door, which we don't feel is a major impediment. Obviously, it's not great, but we don't feel that it really affects anyone's ability to treat patients, but we do think it greatly enhances safety. So just because you're an MR personnel does not mean you'll have access to zone 3 or zone 4. The other important thing to note is that non-MR personnel must be supervised at all times by a level 2 personnel while they're in zone 3 or zone 4. We'll talk a little bit later about how that's done, but you need to actually identify a specific person who is responsible for non-MR personnel while they're in the MR environment. And they should know exactly who is responsible for them when they go in the MR environment. This is all laid out in the new safety manual, and it is a change for many of our sites. These are some examples that I kind of pulled together. So this is my understanding of examples of who would be MR personnel and who would be non-MR personnel. All of our MRMDs, MRSOs, and MRSCs are MR personnel, of course, and should be level 2 trained. They're also going to have this advanced training that we're offering now. So we feel that they will be well trained in MR safety topics. All MR technologists are obviously MR personnel and must be level 2 trained. There should be no MR technologist that's not level 2 trained. Some of our radiologists are MR personnel, but some are not. And it's important to recognize that just because someone's a radiologist doesn't necessarily mean that they need independent access to Zone 3. It doesn't mean that they're even considered MR personnel or that they even have MR safety training. But for the radiologists that do, they can be level 1 or level 2. Some radiology nursing, especially nurses that support complex procedures like pacemaker procedures and perform monitoring during those procedures, are level 2 or level 1 MR personnel. Some of our clinical engineers are MR personnel, mainly because a lot of times those clinical engineers need to go into Zone 4 and do their work. So obviously they need to have appropriate training to do that. They typically have been defined as level 1, although many of them take level 2 training, but that's because they're responsible for their own safety when they're in there. They're not responsible for ensuring safety of you all or patients or anyone else. Same thing applies to physicists. We're in there often alone, testing often at night, as many of you know, when the patient volumes are down. We need to be level 1 trained at a minimum. Most of us are level 2 trained, if not full MRSE trained. Anesthesiology, respiratory therapy, this is a big one. Some radiology staff and even some vendors. So you can think about pacemaker vendors who are going to come in for conditional devices and reprogram devices before and after scans need to have their safety training. Examples of non-MR personnel would be most non-radiology nursing, most administration. So you might have your, your MR administrator might be MR personnel, but Dennis Murphy, the CEO of IUH, and everyone else are not MR personnel, and they are not MR safety trained, and they should not have free access to the MR environment. That can even be extended to security. Of course, security does have access to all parts of the hospital, but if they intend on ever entering any of the MR area, they need to have undergone the appropriate training. Staffing requirements, again, this has been a major challenge of the new manual for everyone. It declares now that there will be a minimum of 2 MR technologists or 1 MR technologist and 1 other individual with the designation MR personnel in the immediate Zone 2 through Zone 4 MR environment whenever patients are present in the MR environment. So whenever patients are present, meaning they could be in Zone 2, Zone 3, or Zone 4, you must have at least 1 MR technologist and 1 other MR personnel in Zone 2 through Zone 4 during that period. During this time, furthermore, the 2 MR personnel must be able to directly communicate within quote-unquote earshot of each other. This is something that's caused a lot of challenges for us because there's been questions about what the definition of earshot is. Could they pick up the phone and call someone? We have landed after some advice from the ACR on a definition of they need to be essentially have line of sight with each other, because this needs to be the type of thing where if there's an emergency in Zone 4, they can yell to the other person to call for help from Zone 4. That wouldn't work, obviously, if they had to get a phone. So this is creating a lot of challenges for us, but we're addressing it at all of our sites, I believe. Additionally, the ACR has adopted VA Responsibilities Directive 1105/05, which came out in 2018, if I remember correctly. It is very comprehensive. They specifically state that anytime scanners are in use, there's a minimum of 1 MR tech per scanner and 1 other individual with the designation MR personnel present in Zone 3 or 4. And there are no exceptions made for on-call, weekend, or after-hours situations. What this kind of really extends these requirements to is that if you have more than 1 MR scanner, you have to have 1 MR tech per MR scanner plus another person who is designated MR personnel within earshot of both of those MR technologists. As it's laid out in this VA document, if one person can be, if the MR personnel can be in earshot of 1 technologist but not the other, then you need a second MR personnel to be in earshot of the other. So from a staffing perspective, it is definitely a challenge. As you can imagine, it's very expensive, and we're trying to come up with different solutions to work towards the long-term goal, which is of actually having MR technologists that outnumber the number of scanners being used in any situation. So what if your department or location can't afford to directly staff 2 dedicated MR personnel at all times? This is an issue, especially we've talked a lot about on-call and weekends or after-hours situations. There are a number of solutions we've tried to develop. So if you absolutely cannot meet this requirement right now, I'd like to talk about 2 kind of solutions that Riley, one that Riley's come up with and one that the Beltway has come up with. At Riley, they have developed an MR safety level rapid test. So it is level 1 rapid testing. It's about 10 questions. And right before that, you kind of go through a brief overview of MR safety that hits all the important points. This allows anyone to come into Zone 2, take their testing, and then be temporarily labeled MR personnel so that they can provide assistance in Zone 3 if in fact there's not another technologist or not another level 1 trained MR personnel already present. Jeff Beatty has set this up in agreement with floor nursing at Riley, such that in these after hours situations where there might be only 1 tech, when a patient is coming down, his folks can call nursing. Nursing will send a nurse down. They will take the temporary training. They will sit in Zone 3 and provide support as necessary while the patient is being scanned. And then once the patient leaves, they will leave. The one caveat with this training is we don't allow it to be used more than for longer than 24 hours, I should state. So taking it today doesn't mean that you don't have to take it tomorrow. Because it's this rapid test, you have to take it every time you come down. Obviously, what we prefer to do is have floor nurses that take the full level 1 MR safety training and are sent down when we need them, because they're recognized as MR personnel already. But we haven't been able to get to that point yet. It's just too challenging for nursing. There's too many people, and there's not enough nurses as it is, and so it has been very challenging. This is something that I would encourage you to look into. If you'd like, I'd be happy to review the system Riley's is putting in place, or get you in touch with Jeff Beatty. I think it's a good system for the near term until we get to the point where we can actually staff at the levels the ACR wants us to staff at. The Beltway has recognized that they, in almost all cases, have CT or rad techs in the area during that time, because their MRs usually share control rooms with those other modalities. And so instead, what they're doing is just turning their CT and rad techs into MR personnel by having them take appropriate training. This is a great solution, I think, because you have actual radiology personnel who are getting training, annual training, becoming MR personnel, and who are going to be there to provide support. So I like this solution a lot as well. Screening. Final authorization for non-MR personnel that enter Zone 3 has to come specifically from a Level 2 MR personnel. Level 1 MR personnel cannot screen non-MR personnel to enter Zone 3. Non-emergent patients should be MR safety screened twice. One of these screenings must be done by a Level 2 personnel, and it should be verbal/interactive. So it should be taking the MR questionnaire, going through it, asking the patient questions, and then making a final decision about them going into Zone 3 or Zone 4. Emergent patients and those accompanied by non-MR personnel can be screened only once, as long as it is by Level 2 personnel. In the ACR document, they do not specify that this emergent screening needs to be using the paper MR questionnaire. Obviously, we want you to use the MR patient questionnaire on everyone, including in emergent situations, but it's not specifically stated that it has to be documented in paper by the ACR if it's an emergent situation. But it is stated that the Level 2 personnel does have to screen them and make the decision to allow them into Zone 3 or Zone 4. Recognize that the screening process for patients, non-MR personnel, and MR personnel are all identical. You shouldn't make any assumptions about the type of forces that a screened individual will or will not encounter. The example the ACR gives is if a mother goes in to provide into zone 4 during the scan to provide emotional support to a child who's nervous or scared, and the child alerts or screams or gets upset, the mother might reach in to grab their hand, and in doing so, she will then be exposed to potentially gradient fields and RF fields that someone who wasn't in the bore wouldn't be exposed to. And therefore, you should make no assumptions. Everyone should be screened as if they're going into the bore. You should always use ferromagnetic detectors. Recognize that they are not a replacement for screening, though, and recognize that they are generally not useful for implants. Some subcutaneous implants can be detected, but you should not be using ferromagnetic detectors as a means by which you verify that a patient does not have implants, because generally they do not work for implants, especially the wall-based detectors. Two kind of summary points from this: we need to have a completed signed MR questionnaire form for every non-emergent patient that enters zone 4. So you need to ensure that you have documented and saved their signed MR questionnaire in their file before they go into zone 4. Non-MR patients must be screened by level 2 unless you can come up with documented agreement not to screen them from an ordering physician. And this is because the emergency is just so great. This should say all patients must be screened by level 2 unless in emergent situations the physician decides that the risk is so great that it makes sense to go ahead and scan them immediately. Gowning is specifically called out by the ACR in their new manual. As all of you, I hope, know, in the system now, at least in the AHC, but we're hoping to push this out everywhere, all patients have to change out of all of their street clothing when they come in. That includes undergarments. The reason for that is that there are more and more cases of patients wearing garments that include silver or copper threading that has been shown to cause serious burns in some cases. It is becoming more and more difficult to identify this type of clothing. Often the threads are so small that they aren't identified by ferromagnetic detectors. So we are requiring all patients change into 100% hospital issued clothing. As those of you who carry out this requirement know, that patients do not love it, and I don't blame them, but it is for their safety. This is an example of one of the posters / pictures that Amy Gallagher had put together for the whole system. And we've gotten these framed and hung up throughout the AHC. A number of other sites have gotten them. If you would like one with your hospital on it, all you have to do is contact me or Amy Gallagher, and we'll get you hooked up with the correct place to get them printed and hung up. I would highly encourage you to do this because it alerts the patients as they're coming in that this is going to be the standard for your site and all of our IU Health sites. With that said, obviously the patients must remove all readily removable metallic personal belongings and devices on or with them, to include all of the stuff that I think everyone is already familiar with, but notably what's been added are these antimicrobial electrically conductive materials. The ACR now advises that patients or research subjects wear site-supplied MR-safe scrubs or gowns in place of their own clothing and undergarments. So we implemented our policy 2 years ago, and really feel like the ACR kind of agreed with us this year, and so we like seeing that. I think we were helping lead the charge in this area. These new antimicrobial clothing articles are definitely of concern and something we need to be worried about. There's some situations where there's pre-approved clothing that can be worn. The Combine is one example of this I could think of, where we will get clothing from the Combine. The physicists will take it and do dual energy CT to look for metal in the clothing. We have done mammography, so high resolution mammography scanning to look for metal threading in the clothing. Sometimes we'll actually do MR scanning to look for susceptibility artifacts. So there are a few cases where non-hospital clothing are allowed. Really, the Combine's the only one. As all of you have seen recently, Amy Gallagher and myself and Ween Liang are are working on testing face masks right now to get you an idea of whether or not there's metal in any of our disposable face masks. We finished all the testing late last night and there isn't any metal, but I'm going to send out an email later today about that. Special patient and worker populations, pregnancy obviously is something that used to be of great concern and still is of concern, but the data has really calmed everyone's nerves around this in the last few years. In particular, healthcare workers are permitted to work in and around all the magnet and the MR environment throughout all stages of their pregnancy. There are no limitations on the first trimester. However, the ACR requests that these folks not be in zone 4 while scanning is on, i.e. we want to limit their exposure to the RF and the time varying gradients, the imaging gradients. The static field though, and the spatial field gradient are not felt to be of concern at this time. Certainly, if you can limit your pregnant workers to not going in zone 4, that's great. But at a minimum, you should make sure that they're not in zone 4 during scanning. For patients, as everyone knows, there are no longer any strict limitations. And this is something that I know Beth Parsley is working on, and she and I swapped emails about this last week. The one caveat is at 3T, the ACR has recommended patients are not scanned for longer than 30 minutes, pregnant patients. So this is kind of the one remaining issue for pregnancy, for pregnant patients and fetal imaging in MR. If you're going to use 3T, they can't be scanned for longer than 30 minutes. Because of that, in MR safety, we feel that you need to have your Mrmd / your MR radiologist involved to help you protocol and ensure that the most important scans are required and that you don't violate this 30 minutes of scanning requirement. Prisoners, of course, can be very, very complicated. We've talked with the folks at Ball and other areas who see more of these than some of our downtown sites. And there are a lot of different ways to go about dealing with prisoners, but prior to the patient arriving to the MR department, notification to the corrections department for an alternative non-ferrous restraining option should be requested, i.e. hopefully they show up with some type of plastic restraining option, not handcuffs or metal handcuffs. It's best that they show up that way. If they don't, obviously they can be changed into that before they enter zone 3 during the screening procedure with the level 2 MR technologist. In some cases, the officer might determine they don't need to be restrained, which is even better. MR screening of the patient and the correctional officers need to take place before they enter zone 3. We need to educate the accompanying officers as to the risks of the static magnetic field. And if they agree, they can accompany the technologist into zone 4 for patient positioning and retrieval. But this, of course, needs to be after they have been thoroughly screened and shown to not have any ferrous or dangerous materials on them, i.e. guns or other weapons. Ferromagnetic weapons should not be permitted in the zone 3 per the ACR. So again, this is what I advocate for, that they should be locked up in zone 2, but they do allow us to continue to bring them in if it's deemed necessary for maintenance of security. This is something I differ a little bit on. I'd rather have our own security provide that security and not provide it with weapons in zone 3 or zone 4. But the ACR still allows for guns specifically to be brought into zone 3 if it's deemed absolutely necessary. Recognize though how dangerous this is. If there's a threat in zone 4, recognize that the officer will probably want to run into zone 4 if there is something happening. And it is of utmost importance that they do not if they have a firearm on them. And it is the responsibility of the level 2 MR technologist to educate the officer about this risk. If you would like to have a gun safe in zone 2 and require your officers to take their weapons off and lock them up, you may do that. Again, we are allowed to be more conservative than the ACR, but because of the ACR stance on this, most of the law enforcement agencies feel like they should be allowed to bring them into zone 3. Be aware of that. Parolees, the one complication, as many of you know, is they can have a tracking device. This has to be taken off before they're scanned. To do this, you need to have them accompanied by someone who is able to take their device off. General topics and implants, devices, objects. All sites must have a handheld magnet greater than 1,000 Gauss or a ferromagnetic detector. A non-ferromagnetic detector, such as the black wands that we all have, does not meet this requirement. You must have a magnet greater than 1,000 Gauss or a magnetic detector. If you're listening to this right now and don't have one of these at your site, please let your administrator know this is something that needs to be changed immediately because you're not in compliance with the ACR requirements. External devices or objects demonstrated to be ferromagnetic and MR unsafe may be brought into Zone 3 under specific circumstances. For example, if they're deemed by MR personnel to be necessary for patient care, but they should be brought into Zone 3 under the direct supervision of a specifically designated MR personnel who are thoroughly familiar with that device and its function. Safe use of these devices while they are present in Zone 3 is specifically the responsibility of a named MR personnel. These devices must be appropriately physically secured or restricted at all times in Zone 3 so that they do not inadvertently come close to the MR scanner and accidentally become exposed to static fields or gradients that might result in them becoming projectiles or potentially not being functional anymore. Finally, all objects that you allow into Zone 3 must be documented for safety evaluation with magnet or ferromagnetic detector. If there is a reason to bring some type of object into Zone 3, that is not already documented as approved to go into Zone 3, you must document that on paper. You should do it in the patient's file per the ACR requirements. There's 3 classifications: MR safe, MR conditional, and MR unsafe. MR safe objects or devices that can go in without conditions. They are non-metallic, non-conducting, and non-magnetic objects that pose no known hazards. The conditional objects are objects or devices that can be safely used in the MR environment, providing certain conditions are followed. Finally, unsafe objects are objects or devices that are known to present safety risks in the MR environment. These are primarily ferromagnetic objects, although they don't necessarily have to be ferromagnetic. Old classifications that you should be wary or cautious of and that you should not use anymore are MR compatible. This is not an approved term by the FDA anymore, and non-magnetic. A lot of our fire extinguishers say non-magnetic. That does not make them MR safe, unfortunately. So these 2 terms are not approved by the FDA anymore. One other 4th term that's floating out there that I use a lot is non-MR conditional. And that is felt to be the same as MR safe, and it is actually a term that is used explicitly by the ACR, but they prefer that we use these three specifications going forward. So try to use MR safe, MR conditional, or MR unsafe as much as possible to be as clear as possible. What happens if you discover an implant during scanning? I know this is something people do deal with from time to time. When that happens, obviously you need to stop the acquisition. You need to contact the Mrmd or a level 2 MR physician immediately. Recognize that when you begin removing the patient from the bore, you might exert greater forces on them than they're experiencing at isocenter. So bringing them out might be more dangerous than having them in there. Obviously, they have to come out at some point, but before you move them out, there's certain things that you should think about. Number 1, you want to immobilize the device if possible. So if the device is on the outside of them, immobilize it as much as possible before moving them out. Try to immobilize their body as well so that their arms or other parts of their body don't jerk around as they come out. The other big piece of advice is to move very slow as you possibly can move. We'll talk a little bit when we get into the physical phenomenon here in a minute. About why that is, how lens forces affect devices while they're in the MR environment. Move slowly though, because you can reduce the torque that is experienced by the device. The other one is to resist the temptation to have the patient sit up as soon as they get out of the bore. A lot of times, as soon as the patient's out of the bore, we want to get them up and out off the table. The correct way to do it is to move them as far out as you can, keeping them parallel to the bore though. That would include if your table can undock, actually undocking the table and bringing them out of zone 4 on the table. The safest way to get a patient out is to keep them parallel to the field and bring them straight out in a straight line. So please try to do that as much as possible. You also need to notify the physician who's responsible for maintenance of the device that the device was accidentally scanned. It may have received some energy or forces, and that the physician needs to verify it's correctly working still. Emergency response, I think we talked about this quite a bit in Emily's presentation last week, but all fire alarms, cardiac arrests, or other emergent service response calls originating from or located in the MR facility need to be forwarded simultaneously to a specifically designated individual from among the facility's MR personnel. So as soon as the fire department or the police department or security is notified about an emergency in MR, at the exact same time, an MR personnel needs to be notified as well. You can do this by working through security to get a designated MR personnel, probably your Mrso or Mrmd, added to the call list so that they are alerted as soon as there is an emergency. If possible, we'd like to have that individual present before the emergency responders get there, for obvious reasons. The first responders are not going to be trained necessarily, at least as thoroughly as MR personnel are going to be, and there is potential for catastrophic events to occur. You should all arrange to prospectively educate your local fire marshals. I know we've been doing a much better job of this downtown in the last year, but we still have a lot of improvements to make. We encourage you to do this with police officers as well. You can send them level 1 training on our website and have them complete that. It's easy for them to do. They don't have to log in with a IU Health login, so it works fine. We haven't had any pushback from at least firefighters so far downtown in implementing this. So I would encourage you to do that. Use our website, send them the link, verify that they took the testing. Remember that free access to Zone 3 or Zone 4 by firefighters or other non-MR personnel with air tanks, axes, crowbars, other things that could be very dangerous, guns, could prove catastrophic or even lethal to those who are responding or to other folks who might be in the vicinity. As part of your restrictions for Zone 3 and Zone 4, you need to clearly have marked readily accessible MR conditional and MR safe fire extinguishing equipment that's physically stored within Zone 3 or Zone 4. Emily had asked in the last talk if you had to have one in Zone 3 and Zone 4. Per the ACR, you just have to have one in either Zone 3 or Zone 4. If you can have fire extinguishing equipment in both, obviously that's better. Recall that conventional fire extinguishers and other firefighting equipment are not tested and verified as safe in the MR environment. They should be restricted from Zone 3. If you see regular fire extinguishers in Zone 3, you need to have them removed. They should not be in Zone 3. Complex settings such as intraoperative, we've talked about. There are a lot of very specific requirements that go along with that. You have many diverse personnel, commonly including interventional radiologists, surgeons, anesthesiologists, nurses, physician assistants, and others. These folks need to be appropriately trained in MR safety. In PET-MR in particular, this is something that we've dealt with downtown. We have a lot of nuclear medicine personnel who are necessary and essential employees in that facility, but many of these personnel have not previously undergone MR safety education that allows them to work in some of these unique environments. So it's imperative that we train these staff and that everyone knows who their level 2 / MR safety officer is in that environment and can go to them for support when necessary. Okay, last thing, we're going to talk once again about the 4 primary physical phenomena in MR that you need to be thinking about when you're trying to make safety decisions about devices or patients going into the MR suite. There's B0, we refer to this often as B0. It's also called the static field, the magnetic field, the main magnetic field, the main field. The units are measured in Tesla. I've worked on units that go down to 0.35 Tesla, the old Hitachi permanent magnets did. We have a magnet that goes up to 9.4 Tesla in Goodman Hall now. So there is a wide range of main field strengths, but they all have a main field that is always on and is very strong. All scanners also have a spatial field gradient. Again, we talked about this. This is where the field is changing across space. So we call this delta B0. This is usually in a range of 5 to 20 Tesla per meter. It can be higher in some cases. It does scale up with the magnetic field. So our 9.4 Tesla scanner does have much higher spatial field gradients than our permanent magnet, or open magnet, I should say, that we have in the beltway. Nonetheless, we need to be aware of these spatial field gradients. As we talked about in my first discussion, they occur, the magnitude of these gradients is highest near the edge of the bore, and it occurs in a donut-shaped area all the way around the bore. So remember, this is a three-dimensional magnet. It's a cylindrical magnetic field, and this spatial field gradient occurs at all points around the bore of the magnet. So one of the things we often come into conflict with is we find that a certain implant is approved to 7 Tesla per meter spatial field gradient, and we see that there's an 11 Tesla per meter field gradient, you know, up here at this part of the bore. But we feel, well, as long as we keep the patient lower, they'll never get too close to that 11 Tesla per meter spatial field gradient, which is true. They won't get too close to this one, but they might get close to the one down at the bottom, or if they move, they could get close to the ones at the sides. Just remember, this is three-dimensional. The spatial field gradient maximums go all the way around the magnet. If you're going to approve someone to go in with a device that has a specified maximum spatial field gradient that is below the maximum field gradient of your scanner, you need to think very carefully about how you're going to ensure their safety and ensure that they do not cross that line. A lot of times we'll have technologists or Mrsos call the MR physicists, and we'll actually examine the device with the technologist and come up with a plan for how best to get them in and out of the scanner safely if they must go in. The best way of dealing with this, of course, is to find a scanner that has a lower maximum field gradient and allow them to be scanned. Of course, there's the RF field, which occurs in the bore, as we talked about in my first talk. The good thing about the RF fields and the time-varying magnetic field gradients is they are primarily constrained to the RF bore. These are measured when you use the B1 plus RMS metric in microtesla. 0 to 3 microtesla is common range. Or if you're talking about absorbed energy, you can look at the rate of absorbed energy in a body, and that's typically 0 to 4 watts per kilogram. We refer to this as B1. So when we talk about the RF field, we usually talk about this as B1. Okay. And then there's, of course, the imaging gradients, which are the crazy loud things that occur and stimulate peripheral nerves in patients, can even stimulate the brains of patients. And that's because they are changes in the magnetic field that are happening very, very rapidly, on the order of 1/100th of a second. We refer to these as imaging gradients or time-varying gradients, as we discussed earlier, dB dt, because it's the change in the main field, B0, as there is a change in time. The typical units for these, we talk about the magnitude most often, which is 40 to 80 millitesla per meter. So that would be the slope of this purple line. But if you look at how fast it's changing, which you can see it's changing very rapidly, that's the slew rate that is measured 60 to 200 Tesla per meter per second is the common levels of the slew rate. Static field issues, of course, there's the missile effect. This is denoted as the attraction exerted by the main field of the MR scanner on ferromagnetic objects accidentally introduced into the MR scanner room. Most commonly, these are oxygen bottles, scissors, chairs. This represents a dramatic risk to the patient or the radiographer. I'm going to show you one thing to keep in mind is the force with which the ferromagnetic object is attracted to the center of the magnet is proportional. It's linearly proportional to the intensity of the main field to the mass of the object, and then it's inversely proportional to the distance cubed. Here's just a few examples from YouTube. This site was decommissioning a magnet, and they titled this "Playing with MRI Before Quenching 2019." Don't encourage anyone to play with an MRI, whether you're quenching it or not. Obviously, I'm not sure this is the most responsible video that I've seen on YouTube. In particular, the first lady who placed something in there, you'll see that she gets relatively close to it as it pops back out. So pretty dangerous. Don't encourage you to do these types of things. We've done some experiments at Riley where we've taken objects that were tied to like ropes, and put them in and taken videos of them. But throwing objects in is very dangerous, as you can see, because the object experiences a torque as it gets to one end of the magnet that will bring it back into the magnet. It experiences another torque that pulls it back in, and it can be very dangerous. I show this to you so you can have some real understanding of the missile effect and how dangerous it is. I know everyone already knows this. If you want to get a better idea of it, feel free to Google. Once you've quenched the magnet, the physician comes in and can easily remove it, so he doesn't understand what all the fuss is about. Spatial field gradients are due primarily to Lenz's forces. Lenz's law asserts that an induced eddy current, this is a circular current that forms in a metal, can be non-ferromagnetic metal, that generates a perpendicular secondary magnetic field that opposes the main field. And that is effectively stops the motion. So if you're moving in with like a piece of aluminum into the field, the spatial gradient will create Lenz's forces in that object that create eddy currents, which are these circular, they look like eddies in the water. They're electrons flowing in circles. When those electrons flow in circles, they create a perpendicular magnetic field that's opposite the main field, and it makes it hard all of a sudden to push. So anyone that's taken aluminum plates into the MR scanner knows if you try to twist them around, all of a sudden it's like, you know, like it's stuck in place. This is because of Lenz's forces and the eddy currents that they create. This does have important consequences in MRI. If an electrical conductor is moved through the spatial field gradient, you will have voltages and current generated in that conductor with a magnitude that's directly proportional to the rate of motion. So that gets us back to moving slowly in the magnetic field, as well as the regional spatial field gradient. That gets us back to not allowing the patient to sit up. When they sit up, they get closer to the edges of the magnet where the spatial field gradient magnitude is highest. When they move fast, the eddy currents are in magnitude proportional to their rate of motion. So these are the reasons physically that you don't want them to sit up, and that you do want to keep them lying down and move straight out as slow as possible if you find out someone has an implant, or if you know someone has an implant, they're going in and you want to protect them from any potential harm, even though you've approved the implant to go in. All right, here's an example of this. I'm going to skip ahead. This is a nice demo you can find on YouTube. I'm just going to skip ahead to like one. This is where the gentleman is showing you can actually it'll almost float because of the eddy currents induced in the aluminum object. And here the gentleman has tipped the aluminum object, and it will tip over, but it's in slow motion. And that's because as it's tipping, the spatial field gradient is creating these circular eddy currents. Electrons are flowing in a circle in this object. That creates a magnetic field that opposes the main magnetic field. And so all of a sudden the motion magnitude is much slower than it would be if the eddy currents didn't exist. It's less as it gets closer to being parallel with the magnet. As you can see, if you tip it the other way, where the eddy currents can't form in the plate, there's almost no effect. RF field issues, these are primarily due to molecular friction. Again, we talked about this in my first talk, but when you have an oscillating RF field inducing molecular friction in polar molecules, i.e. water, the main substance in our bodies, you will create electrostatic friction between the molecules. And this is an inefficient process that results in thermal heating. Various health conditions can impair an individual's ability to manage a thermal crisis. And that includes fever and obesity. This is something to be aware of. There are also medications, including beta blockers, calcium blockers, amphetamines, and sedatives that can alter a patient's thermoregulatory responses under heat load. And there are even certain medications that have been found to have a synergistic effect, i.e. they enhance the heating of RF radiation and molecular friction. These include some general anesthetics, some stimulants. Even caffeine is identified as potentially being one of these substances. If you'd like to read more about this, this is a nice article that was written in 2000, so it is old, but it's by Dr. Shelluck. Mainly, he discusses evidence that's been shown in rats and some canines related to these substances. There isn't a lot of good data on humans to show that these actually will increase a person's temperature in any meaningful way, but something to be aware of. And of course, you can have induced currents from RF fields. and devices, appendages, and coils. We've talked about if you let patients create loops with their arms or their legs, especially their thighs are the most common place where they have thighs touching. They'll have very high resistive load there, and if electrons travel through that path, because of the resistance, you'll have an enormous amount of heat generated. So you can create significant burns. As I mentioned, we're seeing a lot more conductive materials in clothing nowadays. This is something I pulled off the Lululemon screen last night. I went to it and took a screenshot. It's called the Silverescent. And it was that they were just making yoga pants with this antimicrobial stuff. Now it's like all their clothing. Everyone loves it because you don't stink anymore when you're doing your yoga, I guess, but shouldn't wear it in an MR scanner. There are a lot of socks being made now called copper sole socks, and they have this substance called cupron, which is a form of copper embedded in them that fights, that is antimicrobial, not safe for MR. Of course, nowadays, COVID, cupron is in mass now, and this is something we all need to be aware of. Here's an example of this clothing. I had an 11-year-old girl. This wasn't at our facility. She underwent MR imaging for the spine of scoliosis. She wore a gray undershirt under a long sleeve white t-shirt and gray sweatpants. The patient was screened verbally, visually, and using a metal detector. Again, metal detectors don't catch this kind of stuff. She had no snap zippers or evidence of metal in the clothing. It was on 1.5 T scanner with 33 millitesla per meter gradients, so not very strong gradients. Used a standard 8-element spine coil receive only. Some sedation. Her arms were fastened down, and there was no skin to coil or skin to skin contact. So essentially set up correctly. When the patient, during the scan, the patient began to complain of right side burning. You can read more about this in this article. This is an example of the erythema that was found immediately after the scan. This patient had blistering eruption along her right flank. It was a 2nd-degree burn. This is a very serious incident. It was allowed to develop somewhat because the patient was partially sedated. It occurred strictly because she was wearing clothing with silver fibers in it. There was a digital radiograph done later to actually identify these silver fibers. Again, this is why we do not allow people to wear their clothing anymore. Recent research has shown that 5 to 10% of clothing out there that has these fibers in it is not labeled as carrying the fibers. You cannot trust the labeling or the manufacturer. A blanket example, this is something I mentioned when Emily talked last week. This is a 62-year-old woman who was injected with FDG and placed in a waiting room with a hospital blanket. So she underwent a PET MR scan. She had a 20-minute PET MR with 3D T1 weighted imaging, flare imaging, susceptibility weighted imaging, DWI. And you'll see the blanket actually caught on fire and it burned part of the MR scanner. And it was due to the presence of metallic fiber in the blanket. Copper fibers was used by the blanket manufacturer. So again, the blanket was not listed as having these metallic implants, these metallic threads in it. So you did not know. It is very important that we use only our approved blankets when we put them in the MR scanner. I think this is the last one. Yep, time varying gradient field issues. This gets down to those imaging gradients that are responsible for the sound that we hear in the MR scanner and creation of imaging. Patients with implanted or retained wires in anatomically or functionally sensitive areas, i.e. myocardium, epicardial leads, implanted electrodes in the brain, should be considered at a very high risk. We need to be very concerned about faster sequences in these situations. Those will be sequences that use things like EPI, where you're flipping your gradients really fast instead of using RF pulses for image localization. These would be sequences like diffusion-weighted imaging, functional MRI, almost all perfusion-weighted imaging nowadays, MR angiographic imaging. We should be very careful about using these sequences when patients have implanted or retained wires, abandoned leads, for example, in the brain or in these very high-risk areas like the heart. The decision to limit the rate of magnetic field change, that is dB/dt, and the maximum strength of the magnetic field, gradient subsystems needs to be made in consultation with your level 2 MR physician who's overseeing the case of the patient. This is a good example of some work that was done in patients looking at various ECG leads that were implanted in the heart. I'm going to post this with the talks on the website so you can review it if you're interested in it. Okay, that's it. We have done our introduction. We've covered static fields, time varying fields, and implants. We've covered GBCAs. We've talked about quenching and cryogen safety. We've covered, I've given an overall summary of the ACR safety manual and its main changes today. Next week, we're going to talk about zoning, screening, and more designation of MR and non-MR personnel. Then we'll talk about infection control, and finally, the medico-legal implications. And then after that, you all will be able to generate your certificate on our website demonstrating that you have attained your Mrso, Mrmd, or Mrse certification. With that, if there are any questions, I'd be happy to answer them now. I did see some chatting activities, so let me pull that up. Okay. Beth. Yeah, one thing that has been brought up, this is in a private message to me, but we should be aware of, is that there are changes now in the 2020 ACR document that might require some of our sites to change their MR screening document. We recently made these changes downtown. It was somewhat of a cumbersome process, but we use it as a chance to combine a bunch of other questions and kind of make the questionnaire shorter. I would be happy to share that document with any site who might want to use it or copy it or at least learn from the changes we made. But yes, there needs to be an effort to update your MR safety questionnaires based upon the new ACR safety manual. If you have questions or concerns about that, do feel free to contact me. I'd be happy to review your questionnaire with you. Any other questions?
Jason, this is Larry. Concerning pregnant patients, you said no more than 30 minutes of scanning. Was that just continuous scanning, or is there a window for that?
Good question. I want to be clear, that is only at 3T. That 30-minute window does not exist at 1.5T. It only exists at 3T. Larry, it is not like some of our other implants where you are allowed to, where they kind of state that you can count like downtime between the RF pulses or downtime between the sequences. It states that they can have no more than 30 minutes of MR scanning. So I'd be happy to seek clarification from the ACR on this, but right now the ACR manual states that, and I would suggest we adhere to that out of an abundance of caution. And I think the conservative approach would be to keep the sum of all your sequences below 30 minutes at 3T. Obviously, if you can scan them at 1.5, that would be preferable. Any other questions? All right.
Hey, Jason, this is Larry one more time. I did not have a link to this, nor have I received the test, just so you know.
Oh, okay. The test has not gone out. I'm going to send that out right after this, so do watch for that. I just didn't have a chance to get it scheduled before the talk started, but I'll send that out in just a moment. Sorry about that. Everyone, if you are having problems accessing this, looks like we've got some more chats. Let me bring them up. If you are having any problems accessing this, our meetings, let me know, and I can have Julia kind of like resend out the invites every morning to make sure that you have the most recent version. Let's see. From Josh Purdue, did you say that the regular metal detectors would not satisfy the ACR? They need to be fair. That is correct. Those regular detectors, the black wands with the yellow lettering, do not satisfy the requirements. It must be ferromagnetic detector now. If you don't have a ferromagnetic detector or a magnet that is above 1,000 Gauss, you should go tell Josh that you need to order one today. That would be my encouragement. Let's see, another question. Do you have ordering information for greater than 1,000 Gauss magnet? I don't, but I will get that and I will send that out to the group. Let me make a note of that. It's a great point. I don't have a good place to get that. All right, any other questions?
Jason, in the ACR safety manual, is there wording that addresses specifically who is to okay scanning of a patient with an implant? Can it be that any of the three, the Mrso, the MR physicist, or the Mrmd?
So I think the answer to that, Larry, comes down to the type of implant. I'll start with, as we've talked about, and you know, the Mrmd is responsible for it. Could the Mrso or Mrse approve it? And I think the answer to that is yes, if it's a conditional device. And if the scan will be meeting the requirements set forth for that conditional device. Because if it is a conditional device and you're meeting the FDA requirements, conditions that are put down on that are asserted for that device, you're not doing anything, you know, quote unquote risky. I know we don't all feel that way, and many times the techs don't feel that way, and I understand that, but from a legal MR safety perspective, you're following the FDA guidelines. So there is no increased risk, so to speak. The question becomes, Larry, if you're going to deviate from the conditions of the device, or if you need to scan something that is that is MR unsafe, I should say. No, I was about to say non-MR conditional, that is MR unsafe. In those cases, you need to have written approval from the Mrmd. Obviously, I would recommend you consult with MRSEs also and MRSOs, but in the case in which you won't follow the conditions, or you may have to deviate from the conditions, you should have written approval from the Mrmd. Does that answer your question?
Yeah, pretty much, yes. Should we get that when we're doing unsafe pacemakers? Should that be on our sheet?
Yes, yes. In fact, the Mrmd, we don't specify the Mrmd in the current checklist, but that's a great point. We could change it to the Mrmd, but the MR radiologist must be aware, the level 2 trained radiologist must be aware of what's going on and obtain consent from the patient. So they should be heavily involved in that process. That should be on the sheet, Larry. Okay, no more stuff on chat. Any other questions? I apologize, I'm always the longest winded on these talks, and I always feel like when I set up my presentations that I don't have enough slides, but obviously that's not the case. So I apologize for that. I thank everyone for your participation. Like I said, you'll be getting the links for the test here shortly. And I will upload the video to YouTube shortly. For some reason, YouTube takes like a day and a half to